Thank you very much, Sophie, for that introduction, and really for honoring our work by inviting me to present at this prestigious lecture series. Thank you. This work over the past decade did not answer the primary questions we set out to address. Indeed, it has raised many more questions than it answered. So my goal today is to inspire as many of you as possible, especially everyone who's half my age and has your whole career in front of you, to pick up where this work has left off and continue the effort towards solving these really stubborn global health problems. In 2006, the World Health Organization published the first international reference standards for child growth. This landmark project demonstrated that between birth and 5 years of age, children born to healthy mothers who don't have illness, receive an adequate diet, get good health care, are nurtured and live in a clean environment, grow remarkably similarly. They grow at about the same rate, regardless of their race, their nationality, their genetic background, or environmental climate. However, nearly a quarter of the world's children lack at least one of these factors and experience linear growth faltering. This graph shows mean length for age Z-score for children in Latin America, Asia, and Africa, and it shows that the average, the average child at birth in these countries is about a half a standard deviation below the WHO median. And then in Asia and Africa, these length for age Z-scores plummet between birth and about 24 months of age, so that at 24 months, the average child is about -2 Z-scores, or 2 standard deviations below normal. And children who are below that cutoff are defined as stunted. Stunted children are more likely to die of infectious disease in early childhood, to attend less years of school, to perform more poorly while they're there, to earn less money as adults. And stunted girls become mothers who are more likely to have stunted children, driving an intergenerational cycle of poverty and reduced human capacity. Until the last decade, most efforts to reduce stunting focused on improving complementary feeding, that is, adding solids after a 6-month period of exclusive breastfeeding. However, this is the most recent of 3 meta-analyses that have tried to estimate the expected effect of complementary feeding on length for age Z-score, and it shows that improving infant diets will only increase length for age Z by about 0.1. Previous estimates have said maybe up to 0.2. But basically about 5 to 10% of the deficit of the average child in Asia and Africa at 2 years of age might be overcome by improving their diet. Similarly, high rates of diarrhea certainly have adverse effects on growth, but this analysis suggested that eliminating all diarrhea in the first 2 years of life would only shift length for age Z another 0.13. 27 years ago, UNICEF developed this framework for undernutrition, recognizing that stunting prevention will require a multisectoral approach that includes addressing several underlying causes. And central among these was improving water, sanitation, and hygiene. WASH earned its place on this framework because of its role in reducing diarrhea, but also because of very strong observational studies that had been done primarily in the 1980s and 90s. And Steve Esri was one of the real pioneers in this field. And he published analyses showing that children that had access to improved wash services, had latrines or improved water sources, that this was actually more strongly associated with growth in children than it was with diarrhea. In 2009, as Zolfi said, we reiterated a hypothesis that had been in the literature since the 60s and 70s, that the adverse effects of poor WASH on child nutritional status may be mediated not only through diarrhea, but also through environmental enteric dysfunction. This on the right shows a normal gut wall with long villi and no inflammation, and this is a gut wall of environmental enteric dysfunction, where these bright red cells are inflammatory cells, and you see it's flat with the villi are gone. This condition of EED is very common in many, many places around the developing world. This hypothesis further evolved that the adverse effects of poor WASH and linear growth are partly mediated through EED and diarrhea, and that we could reduce EED and diarrhea through household WASH interventions, and that the growth effect of improved WASH would be additive to those of concurrently improving infant feeding. The WASH benefits trials in Bangladesh and Kenya and the SHINE trial, the Sanitation, Hygiene, Infant Nutrition Advocacy trial, were conducted over the same period of time in 3 countries, Bangladesh, Kenya, and Zimbabwe. They were all cluster randomized trials to test the independent and combined effects of improved WASH, improved infant feeding on child linear growth and diarrhea at the endpoint of the trials, which was 18 months in SHINE and 24 months in the 2 WASH benefits trials. Each trial had a separate group of investigators who interestingly came from different disciplines and attacked these questions from very different points of view. The 3 trials have all been published, all in Lancet Global Health over the last 18 months. And this month, there are 2 papers that were published, one in Lancet Global Health and one in BMC Medicine, that are sort of summary or consensus statements about how to interpret the findings of these 3 trials and what they might mean for policy and programming. So I'm going to draw on these papers heavily in this talk, but if you want more detail, there are supplementary tables and appendices and all kinds of things that go with these papers. Both WASH benefits trials were 7-armed trials, and they wanted to test the effects of different WASH interventions. So they had a water chlorination only, a sanitation only, a hand washing only arm. And then they had all 3 of those WASH interventions together in a combined WASH intervention. They had an infant feeding only arm and a WASH plus infant feeding. And then they both had double-sized control groups. One important distinction that I'll come back to later in interpreting these findings is that in Bangladesh, this control group was passive. And by that I mean that children in the control group were only visited to measure outcomes, whereas in Kenya and in Zimbabwe, the control groups were active, meaning that those children received as many visits from behavior change promoters as the active interventions did. Together, the 3 trials enrolled more than 19,000 pregnant mothers and measured the length of their babies on more than 15,000 infants at endpoint. All 3 trials measured child length, the primary outcome, by study staff who were regularly standardized against a gold standard. But what I'm going to pay some attention to now and take quite a few slides to show you are what the interventions actually were. And that's for a couple of reasons. First, I want you to see exactly what it is we tested. It's one thing to say improved WASH, and it's another thing to see exactly what it was. But second, because much of this stuff, both the infant feeding arm and the WASH arm, is dependent on behavior change. And behavior change is dependent on the quality of the intervention. And that's hard to objectively say. And so what I want to do is describe what we did in all three trials so that you can maybe decide for yourself whether you think these were high quality interventions or not. I want to just say that even though I'm a nutritionist, I'm not going to talk much about the nutrition intervention. The nutrition intervention in all three trials was complementary feeding modules and counseling, several sessions of complementary counseling, and the provision of 20 grams a day of a lipid nutrient supplement, which was the small quantity lipid paste nutrient supplement that was especially designed for Africa in its micronutrient content. So the WASH intervention was designed to be a proof of concept trial. At least in Zimbabwe, we never really thought that we could roll right from our trial into a program. And the reason for that was that we wanted to actually demonstrate that what actually would cause an improvement in growth. And so this intervention was designed that we wanted to do everything in our power, reasonably in our power in this context, to minimize fecal ingestion in children in the washrooms. So that was the goal, not to implement a WASH intervention, but to minimize fecal ingestion. All three trials spent several years. We started in 2006 and we didn't enroll the first child until 2012, doing formative research to understand and decide how to create these interventions. And I just counted up, there were 15 publications across the three trials just reporting on this formative work. So for example, in Zimbabwe, we knew that water access would be an important determinant of hygiene behavior. And so before we started, we inspected all 6,108 water sources in the across the whole study area, whether or not they were functioning and the quality of the water that they produced. And we took the GPS coordinate of those water sources, and then we took the GPS coordinate of every household living in those two districts, so that we could calculate the average distance between every household in the study area and the nearest source of water. And the main reason for doing that is that we couldn't do anything much about water access. And so we wanted to be able to make sure that it was balanced across our treatment groups. And so within each cluster, the cluster would be balanced on distance to water. So just in this, you can see this little triangle is a source of improved water. And every one of these little dots is a household. This is 500 meters, and this is a 1,000-meter radius. So you can see that water access was not very good. There were quite a few households, all these households that are further than 1 kilometer away from an improved source of water. All three trials, this one is of Chitambo formative work, conducted direct observation and other types of formative studies to understand key WASH practices and barriers to optimal behaviors. And in particular in SHINE, we did a baby observation study where we spent 6 hours watching 25 children and recording everything that they put in their mouth. And the reason for this is that we wanted to understand the unique pathways of fecal-oral microbial transmission that might be there for young children and infants. Through this, we learned, for example, that children play on the ground. And they put their hands, which were virtually never washed with soap and water, into their mouths, on average 6 times an hour. We also observed that children eat on the ground and live closely with many animals, especially chickens. All three trials documented that geophagia, which is the purposeful ingestion of soil, was very common in these sites. Even at the very end of our trial, we went back and repeated this baby observation study, and kids ate soil on average 5 times in a structured 6-hour observation period, where they're actually putting stones, handfuls of soil in their mouth. And you can imagine what's in that soil with all these chickens also cohabitating and depositing their poop. Now, here are some conversation starters for the weekend. Did you know that today, on the surface of the planet, there are 3.9 trillion kilos of feces, of fecal mass? And of that, 20%, 780 billion kgs, come from chickens. And do you know, too, that chickens, that the vast majority of rural people living in low-income settings rely on poultry husbandry for both income. Many use it like a checking account, or a short-term savings account where they sell a chicken when they need to pay school fees, and also, of course, for animal source protein foods. So you can see this double-edged sword of living with chickens. Based on this, I, being a former dietitian, calculated the E. coli per average portion size consumed by children of each of these things that we saw them put in their mouth. And while drinking water was heavily contaminated with E. coli, the amounts, the volumes drunk by mostly breastfed children were so small that the amount of E. coli they ingested from contaminated water was really small compared to the amount that they ingested from wet, shaded soil or whole chicken feces themselves, which 2 children put the whole chicken feces right in their mouth. So because of that, our WASH intervention included this thing, which was a 3-meter square washable mat and a little yard. And the reason was that we were going to do all this education to mothers about how it was dangerous for her kids to eat chicken feces in soil. And our social worker said, Jean, if you're going to tell them that it's not a good thing and that it's hurting their children, you need to give them a tool, because they're very busy and they're not going to be able to watch their children all the time. So they need to have some clean, safe place where they can put their child when they need to start the fire or use the bathroom or do some cooking or otherwise not pay close attention. And so we had this clean baby play space that was part of the WASH intervention based on that formative research. The second part of developing these interventions is that we provided highly valued WASH hardware that people really wanted. So in Zimbabwe, that was a Blair ventilated improved pit latrine and 2 tippy tap stations, one at the latrine and one in the kitchen. And this is just to give you an idea of the scale of that undertaking of building 2,500 latrines during implementation of the interventions for every WASH woman. We built the latrine within 6 weeks of her enrolling into the trial. And at the end of the trial, for ethical reasons and to get community buy-in, we built the same latrine at the infant feeding only and the control arm households. So in all, there were 5,000 of these built. We employed a lot of people in the area to make a lot of bricks and mold slabs and build latrines. Behavior change communication. For all 3 trials, it was built and based on published models of behavior change therapy. And all 3 trials had messages, tools, and participatory activities that were extensively piloted. This is just a game that we developed that we called Shit and Ladders. It was a review module for the families in the WASH arm after they had had several modules where if they landed on an improved behavior, it was the ladder going up, and if they landed on a bad WASH behavior, they hit a snake and they went back down the board. And the idea was that it was something they could do together with the village health worker and with the whole family to review all of the messages that had been delivered. The third part, across all trials, all 3 trials, these interventions were delivered during home visits. And the people who delivered them, the behavior change promoters, were chosen to be respected people from those communities who were then continuously trained and supervised by study staff. So in Zimbabwe, these were Ministry of Health, village health workers. And here's a village health worker giving a module to a mother and being supportively, I hope, supervised by one of the study nurses. Finally, we delivered all the commodities to the doorstep of the participating houses, all 3 trials. So we delivered soap and chlorine to the WASH households, and we delivered lipid paste nutrient supplement to the nutrition households. And the purpose of this was so that constant access to these commodities would not constrain use and would not introduce variability in the intervention. These efforts paid off in that we had good intervention implementation fidelity and uptake. Not perfect, but pretty good. At 1 year into the trials, virtually everyone in Zimbabwe and 90 to 95% of the households in the WASH benefits trials had an improved latrine. Most of the WASH households had soap and water observed at the hand washing station, which was an indicator that all 3 trials used of hand washing actual use and hand washing behavior. The indicator and the intervention that had the poorest uptake was point of use chlorination drinking water. They achieved pretty good detectable levels in Bangladesh, but only about half the samples had detectable chlorine in the 2 African sites. The only other thing I can say about that is that it was a very rare behavior in the control groups. So even with this kind of uptake, we still created quite a bit of contrast between the control and intervention arms. In all 3 trials, the infant feeding intervention increased length for age Z-score exactly what the nutrition and pediatric literature had suggested it would. It increased it by between 0.13 and 0.26 of a Z-score. I can just point out that in SHINE, because we had a high HIV prevalence, we pre-described that we would be reporting all our results stratified by maternal HIV status. So there was more stunting in the babies born to positive mothers. And interestingly, the IYC of intervention seemed to have a bigger impact on those children. In all 3 trials, the WASH interventions had absolutely no effect on linear growth. And here you can see the change in length for age Z due to WASH. And here you can see all of those being extremely close to 0. In Bangladesh, all the interventions, except the water treatment only, reduced diarrhea by a relative proportion of 35 to 40%. So these are the absolute change in diarrhea due to the interventions in WASH. And this is the relative change, and you can see a ratio of 0.6 to 0.7. The water chlorination only had an 11% reduction, which didn't meet statistical significance. In the African sites, none of the WASH interventions reduced diarrhea. And I can just share personally that when I looked at the stunting results, I felt terrible disappointment. And when I looked at these diarrhea results, I felt shame. I said, what did we do wrong? Everyone knows that WASH reduces diarrhea. How could we have done all this and not see a reduction in diarrhea? So the first is, how can we reconcile our results across all 3 trials with those classic studies that Steve Esri did 40 years ago, demonstrating this strong association between sanitation and child growth? Well, when I went back to look at all that again, I found that actually these observational studies have really burgeoned in the last decade especially. We conducted a systematic review of all observational studies published over a 4-year period between January of 2015 and December of 2018 that reported determinants of child stunting in low and middle income countries. These kind of papers are usually based on DHS data. They usually have titles like Determinants of linear growth faltering in the Philippines, Risk factors for stunting in Nigeria. And when you go and you look at them, what they've done is take a DHS survey, put in all the things that are measured in the DHS survey, and try to see what predicted us having a stunted child in that same household. And what we found is 63 papers in just that 4-year period reported that at least one household wash factor was significantly associated with linear growth of a child living in that household. That is, in 36 papers, having a latrine at the house was significantly associated with better linear growth of a child also living in that house. Having it, using an improved source of water or treating the drinking water prior to use, 31 studies, it remained statistically significant determinant. And what is so important about this is that these remained in those final models after controlling for really strong factors associated with stunting, after controlling for birth weight, maternal height, maternal education, and household wealth. So we know you would look at so many of these papers and the final model would have 6 things in it that stayed, 6 factors: birth weight, gestation age, maternal height, and having a toilet. How could this be? Well, we wanted to understand this better, so we went back to our own data in the 3 trials, the 2 WASH benefits trials and the SHINE trial. And we reanalyzed the data from the control groups in these 3 trials, but this time treating those mothers and children like they were a DHS survey, like it was well, better than a DHS because it wasn't cross-sectional. It was like it was a prospective cohort. And in regression models, we identified what maternal and household factors at baseline in these trials when mothers were pregnant predicted stunting or linear growth at the end at their child at 18 months or 24 months. What we found is that in all 3 trials in the control groups, houses that had an improved latrine at baseline had a child at the end of the trial that was 0.2 length or age z-score longer than houses that did not have an improved latrine. Yet building latrines in these same communities at the same period of time had no effect on linear growth. We believe what this means is that latrines are some kind of indicator of household well-being that is something else besides the latrine itself. That is, the latrine data is being confounded by something that it's associated with that is strongly predictive of stunting, even after we can control for everything else that we measured in these trials or that a DHS might measure. And it's really caused the investigators of these 3 trials to step back and be much more cautious about interpreting observational causal inference from observational data, especially for WASH studies. How can we reconcile the results of no effect of WASH on diarrhea in the African sites with the 30 to 40% reduction achieved in Bangladesh and with the 25% average reductions in diarrhea from point of use water treatment and from hand washing that both came out in Cochrane reviews in 2015? Well, one of the salient differences, there were 2 salient differences between Bangladesh and the 2 African sites. One was the type of control group. But the other was the contacts per month between the promoters and the participants in the active groups. So in Bangladesh, the control groups were never visited by promoters, but the intervention groups were visited on average 6 times a month. They went once to twice a week, reminding and delivering behavior change messages. Whereas in Kenya and Zimbabwe, the behavior change promoters went once a month, primarily because of our much more sparsely populated rural settings. So we conducted another systematic review to try to get our heads around this, to examine all the evidence to date for these 2 particular interventions, point of use water treatment and hand washing promotion, this time not on stunting, but on diarrhea. When you pick up a UNICEF bulletin and it says, hand washing reduces diarrhea by 25 or 30% at the first line, where is that evidence coming from? What studies is that line based on? So we went back to find all these studies. The purpose was not to re-estimate what the Cochrane reviews had done, to re-estimate the average effect, but instead to identify characteristics of the studies that did and did not report reductions in diarrhea. So I started with studies that were included in those 2015 Cochrane reviews, and then I used the same search string that the Cochrane review had used to identify any similar studies that had been published since 2015. And with this process, we identified 12 hand washing promotion studies and its effect on diarrhea, and 23 point of use water treatment studies and its effect on diarrhea. We extracted all kinds of the usual factors in doing the systematic review, but we added an important one, that in fact no systematic review of these interventions had ever extracted before. And that was, who was delivering the behavior change intervention and how often did they deliver it? How often was the contact between the participant and the promoter? And so I'll just, all the summary of all of that is in the papers and supplementary material. But just to summarize what we learned, virtually all, and by that all but one, which is a special situation that I can talk about, of the published evidence, the point of use water treatment and hand washing promotion reduced diarrhea, come from efficacy studies in which the participant was visited daily, weekly, or at most every 2 weeks. Moreover, in 3 examples of studies which went back to these populations after they had measured a huge impact on diarrhea from one of these interventions, they went back to see what had happened to the behaviors once the trial interventions stopped. And in those 3 situations, the behaviors had sharply declined and the difference in diarrhea between the intervention and the control groups had disappeared. What are the implications of this? It suggests that these 2 interventions specifically now, point of use water treatment and hand washing promotion, when implemented through sporadic message delivery, like community health clubs, social marketing, pamphlets and posters in health clinics, or messages that are delivered whenever the environmental health technician or the village health worker drops by the house, are unlikely to reduce child diarrhea, at least amongst children under 2. Further analyses from these 3 trials have emerged over the past year, which have looked at pathogen exposure and pathogen infection. So in Bangladesh, again, which was the most intensive behavior change intervention, their WASH interventions did reduce E. coli in water and food samples. But the flip side, that's what's in the abstract. The flip side is what was still there. And so the persisted is, this is what was still there in the WASH arms or in the WASH children in the Bangladesh trial. Half of the water samples and 40% of the food samples still had E. coli. And there were no reductions on hands, soil, or sentinel toys. WASH Benefits Bangladesh achieved a very nice, statistically significant 25% reduction in Giardia, but almost a third of the children in the WASH arms still were infected with Giardia. The WASH Benefits trial did a great job of statistically significantly reducing hookworm infection, but 6% of the WASH children were still infected with hookworm. And the soil had over 120,000 most probable number E. coli per gram, and they documented extensive animal fecal contamination and more frequent geophagia in Bangladeshi children than the comparison group of children they studied in Southern California. So it seemed to be, my husband said, well, those Bangladeshi children had a lot more interesting things to explore than those Southern California children. But even more of this hand-to-mouth and object-to-mouth behavior in Bangladesh. In WASH Benefits Kenya, they measured a significant reduction in E. coli in the water with the water treatment only, but still 2/3 of the water samples had E. coli, and there was no reduction on the other things they measured. They had a substantial reduction in Ascaris infection, but still 18% of the WASH children were infected with Ascaris, and there was no effect on Giardia, which remained prevalent. And about 40% of the mothers reported geophagia in the past 7 days. In SHINE, we did not do as much exposure measurement, but we had worked very hard on reducing geophagia. And it was heartening to see that at least reported geophagia was reduced. But I thought it was amazing that still a quarter of the mothers in WASH, even though they would have every reason not to tell us the truth, said that, yeah, their child had eaten soil yesterday. When we did a measurement of actual infection from stool samples of WASH and non-WASH children using molecular methods, this is using the TAC card in Eric Haupt's lab in Virginia, we reduced the WASH intervention reduced total parasite carriage by the smallest of tiniest of amounts, and there was no effect on transmission of any viral or bacterial pathogen. What can we say? Despite high implementation fidelity and uptake and statistically significant improvements in behaviors, presence of hardware, and even exposure to an infection of some of the pathogens, the kids in the WASH arms of these 3 trials still experienced very high interpathogen exposure and infection. Across the 3 trials, enteric infection rates in the WASH arm children were about 10-fold higher than similarly aged children in high-income countries. What we may have done with these WASH interventions is take these environments which are contaminated in the superstratosphere and reduce them from here down to here. And what we need to get to for child health is way down. So what's the bottom line and what can we conclude? Elementary household level WASH interventions, improved pit latrines, hand washing stations that are not attached to a water source, point of use water chlorination are unlikely to improve child growth, even when they're implemented with high fidelity, provide free soap and chlorine, and include intensive high quality behavior change communication. And implementing these elementary WASH interventions concurrently with complementary feeding interventions are unlikely to improve child growth more than implementing the child complementary feeding intervention alone. Elementary household level interventions are likely to be too ineffective at interrupting fecal oral transmission of enteropathogens to support normal growth and development. And so this transmission remains very high. Our findings do not challenge the biologic plausibility that excellent WASH services are critical to child health. That really remains irrefutable. Our findings do challenge that the level of WASH interventions typically offered through many WASH programs in low-income rural settings are not enough. The frequently reported association between household level interventions and child linear growth are probably confounded. Particularly owning a latrine is likely to reflect household well-being in some way that's not accounted for after adjusting for a wide array of socioeconomic factors. What can we say about WASH and diarrhea? Hand washing promotion and point of use water chlorination do reduce diarrhea when these interventions are delivered with very high intensity and adhered to with very high adherence. But so far, the only way that level of adherence has been achieved in a published study is with going daily, weekly, or at the most every other week and having that kind of intensity. Since this is really not feasible for programs at scale, these two interventions are unlikely to reduce child diarrhea unless we can find alternative means of achieving very high adherence, which can be feasible for program implementation. I've had a lot of rotten tomatoes thrown at me in the last 18 months in discussing these findings to the WASH sector and gone to WASH sector meetings. And the two main pieces of very important feedback from them are to underline that these trials did not test two components that are promoted in the new SDG 6 for WASH. The first is to end open defecation and to have complete separation of excreta from humans with safe treatment in situ or transport and treatment off-site. We did not do that in these trials. And the second is water access. None of these trials improved water access. I kick myself because we were going to do this. The original reason of the water survey was to identify where we needed to drill boreholes so that we could raise the level of water access to at least 500 meters. And we got to the end of the survey and we would have spent millions and millions of dollars. And of course, what I should have done then is said, well, we can't do the study here. But I didn't do that. I was convinced that we could measure it as a baseline factor and control for it. But I do think that it was a limitation, especially in Zimbabwe. It is interesting that water access was not a problem in Bangladesh. They generally, almost all households did have on-plot water in Bangladesh. We're calling for research to identify interventions that can radically reduce fecal contamination in the household environment. And we're calling this thing transformative WASH, even though we haven't really defined what this term is. We have some ideas of what it's likely to be. So it's likely to be the SDG 6 for water, which is the amazingly aspirational, ambitious goal of delivering on-plot, continuous access water that is uncontaminated to every household in the world. There are 2.1 billion people who don't have this right now. The cost of delivering it is enormous, and right now we're more than a century away in sub-Saharan Africa with existing approaches to delivering this. Transformative WASH is likely to include interventions that reduce user burden. Poor people spend much more time, effort, and a higher proportion of their income than wealthy people on WASH. And we need to reduce that burden to make it easier for them rather than expecting them to make these very big and substantial behavior changes. So more infrastructure and less dependence on behavior change is likely to be a part of transformative WASH. A good example of this is Amy Pickering's paper last month in Lancet Global Health, where she reported that an inline drinking water chlorination, where at a municipal water point in urban Bangladesh, reduced diarrhea by 25% in that community, even though so it was basically chlorinating the water at point of use. People couldn't, blinding worked very well. People couldn't guess whether they had chlorinated water or not, so they were using water that they didn't know was chlorinated. So it was an intervention that people weren't even aware of, and it reduced diarrhea by reducing user burden. And finally, we really think that complete separation of animals and their waste from where crawling children play and eat is going to be needed to achieve this. And this is going to be a huge cultural, contextual intervention to achieve this. And I'll just point out that my colleague Andy convened a really nice meeting in May in Harare of veterinarians and microbiologists and child health specialists to begin to brainstorm this. And this is published in August of Lancet Planetary Health, a small viewpoint called Putting the A into WASH, where A is animal, and an integrated One Health approach. Last slide. To me, the most affirming thing that's happened since we broke code is that the Lancet editor, Richard Horton, has commissioned a WASH summit. This actually didn't happen in June, it's gonna happen in October, where he's convening some people to call for bold new ideas. None of the, not the usual rehash is what he's said. I want to acknowledge the generous support of our donors, the Gates Foundation, DFID, and Wellcome Trust, and the army of people that did this trial, especially in Zimbabwe. Thank you.
We'll take a few questions, right, Jean? So the floor is open for questions, and as I indicated, press the button and you'll be put in queue and wait till the light stops, and that's your cue to speak. So maybe I can start off, Jean, by saying this. You know, your studies have turned a lot of things on their head, and I ran into Manoj Manohan just 3 days ago, who's been evaluating the Swachh Bharat program of creating these large number of pit latrines, but without any link to sanitation services or cleaning services. And what he was saying is basically these are being constructed and not being used in many areas, and actually having them near households increases the risk of contamination. So, tell us what you think might be a way forward in terms of reducing open defecation. I mean, is it something for which there is a shortcut or no shortcut?
I don't think there's a shortcut. And I think we have to have very high quality of sanitation, especially in more densely populated areas. And so I think simple sanitation isn't going to do it in more densely populated areas. I think this idea of building a toilet versus inspiring people to build their own toilet, that is a huge discussion and debate in the WASH sector. And many, many people have told me that the reason that these trials failed is that we built the latrines. And we gave them a latrine, and so they didn't use it. And what I can speak to in Zimbabwe is that that absolutely wasn't the situation. We had 50% open defecation at baseline, and the reason people didn't have a latrine is that they couldn't afford to buy the amount of cement that constructing one required. They all had to have lined pits because the sandy soil, they just collapse immediately, and people just haven't had that money in the last 20 years with the economic decline. So we know that they're very, very highly valued. That is not the case in all cultures. And in some cultures, even if toilets are there, people don't want to use them, and that's a whole nother level of challenge. And no, I don't think there are any shortcuts.
Thank you. Please.
Hi, thank you so much for that. Could you speak a bit to the context in which the 3 studies were conducted? Like, were they more on the rural side, on the urban side, and just speaking to how the density may have affected the results?
Yes, sorry, I should have said they were all rural sites. So these trials really speak to rural areas of low-income countries and not to urban. The most densely populated of the three was Bangladesh. Kenya was in the middle, and Zimbabwe was the least densely populated. I have a table somewhere which gives the exact numbers, and I don't know where it is, and I can't remember, but there was a range.
Thank you.
So we've been live streaming your talks. So we have a question from the web. It says, what about child-led models of WASH, where there is likely to be sustained promotion of hand washing among peers and within schools and households? Do you have any views on this?
I think that hand washing is definitely something that can be promoted, but it's unlikely to have high uptake if there isn't ready access to running water and soap. And to expect hand washing to happen where the only way it comes into a household is on the head of a woman, and it's long walks and with 20 liters at a time, to use that precious commodity for hand washing isn't going to happen. And that's why I'm very interested and passionate on new technologies that might be able to leapfrog us into getting access to water at the household level. Including schools.
Including camps.
Yeah, and I would just say, if I can just say one thing too that really has influenced me. Amy Pickering pointed out, she's an engineer that was involved in the Kenya study, and she said, the literature on hand washing amongst doctors and nurses in ICUs in North America is that for years, every kind of behavior change intervention did not reduce nosocomial infections in hospitals. And there was not good uptake, despite trying to have peer support and, part of your performance evaluation and try, all kinds of things. And what finally affected those rates was putting hand sanitizer at the bedside of every single patient, so that it is and at every elevator and at every room, so that it becomes a mindless, very easy thing to do. And that's what finally worked. So I think it's more about removing those behaviors and putting that kind of infrastructure, removing those barriers and putting that kind of infrastructure in to make these behaviors very easy.
Please.
Hi, I have a comment and a question. So I am a
Please introduce yourself.
Okay, so my name is Bhairavi. I'm a speech pathologist. I am from India. So this is very, very close to my heart, because I understand from the implementation science point of view, what looks awesome on a peer-reviewed journal is very tough for us to follow. It's an important 5-mark answer for a student. That's it. We see all this research as difficult to understand. Maybe we can leave this as a choice in an answer sheet when we write exams. That's all we see this as. But the comment is about the impact of Swachh Bharat and what WASH program translates to another Asian country like India. So I work on gadget exposure in children, and the first advertisement for any rhyme is the Dettol, which is a hand wash for a child. And that's something that annoys everybody. And we're all from the middle class background, and that's what it means to us. So, oh my God, that ad on washing your hands, that's so annoying. So that's what we see. That's what a middle class child sees, and it's a screen time problem for us, because that's the most interesting ad. It's difficult for us to not see it without getting annoyed. We don't take the message. We don't understand the message that we have to wash the hand. That's why they're playing it. The other question is from the clinician standpoint. So when we look at research papers as a clinician, when you come with a vulnerability telling that we started with WASH will be effective, but it didn't work. But most often what happens is when we take a program and say this helps apraxia, this helps autism, and we don't see such a result, for a clinician, it's like, so what helps? So you started, it says it helps. So can we continue doing what we're doing with not really looking for evidence-based practice? Can we just do whatever looks good and not look at research? Because research is not telling us, informing our practice. So how does a clinician look at research? like this? That's my question.
Stop.
So, sorry, if I can just rephrase, I think you're asking me, do I think WASH interventions and WASH programs should carry on doing the things they're currently doing,
Yes. So
even though we
research
haven't
doesn't
been
have
able to
yes.
prove that they're improving health?
Yes.
There are a good many benefits from WASH interventions that are not health, from some WASH interventions that are not health. Building a latrine is very good for women's security, for privacy, and for integrity, dignity. And all of those benefits are met by those latrines we build, even if we didn't improve children's health. And that is a vehement message from the WASH sector many, many times. And I accept that, I very much accept that. What I don't think, though, is hand washing promotion or point of use water treatment. They don't improve women's security. Maybe they do a little bit for dignity, but they don't seem to have, they are promoted for health reasons. And so if they don't have a health impact in the way that they're currently being promoted, do I say stop? What I say is we need to do whatever we can to stop tweaking these things and get into some step changes in the kind of WASH services that we're able to deliver to people in rural areas of poor countries. And that's what I most hope. It breaks my heart to see these kinds of, lots of money getting spent on these kind of programs that are probably not changing behavior and probably not having a health impact.
Wonderful presentation, dramatic and beautifully presented. Thank you so much. 2 questions for you. First question may be a silly question, but children around the world, not just children in Africa and Bangladesh, put their hands in their mouth. It is a typical characteristic of children, certainly under the age of 2. When they crawl around, even in North America, they're crawling on the floor, they're crawling outside in the garden, and maybe there's no animals around. Maybe that's the answer to the question I'm going to ask. But why is it that children in a, quote, cleaner environment don't get as much diarrhea as kids in a dirtier environment, despite the fact that they put their fingers in their mouth? I have a second question too, but maybe you could answer that first.
Yeah, no, I think it has to do with what goes on in their hands when they're crawling around, and the intense fecal contamination of these environments that therefore get on their hands. And yes, even if they're crawling on the floor in the United States or in Canada, they're usually crawling on green grass or on a tile floor that can be washed with soap and water, or on a carpet, or, you know, it is nothing the same as loose soil that is ground up chicken feces.
My second question is related to what you started off the lecture by saying. You said in your first comment that for the people half your age, take over from me with this type of research. You didn't say what this research costs, but I imagine it was in the millions and millions of dollars.
Millions.
And the results are phenomenally informative, if not positive. Maybe positive is the wrong terminology, certainly informative. So you have this conference talking about innovative solutions, but what are the next steps? What are you challenging the audience in this room to do?
I can tell you the things that the things that we've been working on at Chitambo are this animal challenge. We would really like to take that on in rural Zimbabwe and figure out how that might be done in a culturally, socially, financially, economically acceptable way to make their environments cleaner. And I personally have been trying to connect engineers in the water, in the emerging technologies in water. And because I don't have the training or the years ahead of me to do any of that. And I think that that is going to be a critical factor, is water access, at least for sub-Saharan Africa. And close, convenient, uncontaminated, continuous water access. Most water in developing countries is intermittent. And so even if it's piped, it's intermittent, and so it's contaminated. And so, maybe things like this inline chlorination sort of device, that only works on a small proportion, that particular device. So I think there's a lot of engineering that needs to be done. And my plea is to try to get smart people interested in these and applying themselves. So there's a woman whose work I've been following for a couple of years. She's the chairman of mechanical engineering at MIT. And she's been working on atmospheric water harvesting. And which everybody at the WASH sector, of course, rolls their eyes and laughs at this silly nutritionist talking about a high-tech thing. What it is really is a device that pulls clean water out of the air. And it would be potentially a way to get water access off the grid, because it uses an absorbent, it's completely dependent on solar power. It has an absorbent material, especially developed material sciences, people working on it kind of material, that pulls this water out and then it condenses and is clean. It is probably 50 years from something that could be, but maybe that's sooner than 100 years to lay pipes. And it reminds me of cell phones and solar panels that have revolutionized rural living, in that people would really look after their atmospheric water harvester on their roof if that was providing the water, whereas it is harder in these places where pipes are a publicly owned property and to keep them maintained. So I've succeeded in pulling 5 engineers together and have a meeting. And then that'll be that. Then I can retire from that. Yeah.
Final question from the floor.
Hi, Dr. Humphrey. Thanks very much for your presentation. I found your findings were just fascinating. I have 2 questions for you. My first question is, from what I understand from your presentation, building latrines didn't have an effect, but actually having an existing latrine was what was actually having this effect. And so you suggested that having a latrine was indicative of something else. So my question for you is if you have any ideas for what that something else might be. My second question is
why don't you wait, because I can't remember things very well. That's one of the things one of you smart people could try to figure out. There is something different about families that have prioritized building a latrine and using it from families that haven't in resource constrained places. I don't know what it is, but whatever it is, we can't adjust for it with everything else that we measure, especially in these trials where we measured zillions of things, covariates to try to adjust in these models, and that are, so I'm not sure what that is. And just to make sure that we really careful in your language when you're talking about effect and association. So having a latrine is associated with improved linear growth. Kids that live in a house, on average, with a latrine grow better than kids that don't. But we don't think it's the effect of the latrine.
right.
We
So
think
this
that
is-
latrine represents something else about that family that helps that child grow. Sorry, your second question.
That's okay. Thanks so much for that. My second question is unrelated, but you had mentioned that you had some pushback. You had said that rotten tomatoes were thrown at you when you started presenting some of these findings. I was wondering if you could tell us a little bit more about this, and if you think your findings are going to change the ways in which development partners run their programs.
It's been we broke code two years ago next month, and it's been a very long 2 years. And I would say we've made a lot of progress. And part of that has happened because I and the other investigators of these trials have had a lot more time to think about it and to listen to the WASH sector. It's been a very good, painful, difficult, but very good experience to dialogue with the sector more about what this means. So I think as you would expect, I think the initial reaction was defensiveness. Or people's livelihoods, people's whole purpose in life for years and years and years has been doing these things. And and they're worried that, I mean, people told me this, you're gonna cut off our funding, you're gonna, all these things. So people were emotive and angry and hurt and everything, and then I would listen, and then I would say, well, I didn't say that very well. I was much too, I didn't have enough caveats in what I said, or I wasn't, thinking about that. And so we would go back to the drawing board, and that's why these interpretation papers that are just out this month have taken so long. It's been a round and round and round and round to get the nuance so that the 20 investigators on the Lancet Global Health paper, who were all investigators of the 3 trials, would come to consensus and agree. And then the reviewers would, and so it's been, so I think that there's been pushback and then greater understanding and then thinking about it more deeply and then thinking, I think everybody has been thinking. And I think there's been a lot of growth. And that's why I think that Richard Horton calling for this meeting is a real milestone, because it suggests that people are saying, right, okay, so what are we going to do? We need some really big, bold new ideas. And that feels very affirming.
Well, thank you so much, Jean. And thank you for being bold enough to do these studies, which I think, even though they may have been negative, have pushed the frontiers of science forward. So we know a lot more from negative studies than we do from trials that only go in one direction. I have to tell you this, I was the external reviewer for the SHINE extension. And I think the investment that the foundation and others made was worth every cent. So thank you so much for doing this.
That's the most affirming thing I've ever had.
So thank you very much, ladies and gentlemen. Dr. Humphrey will be here. And you can ask your questions. Thank you very much for coming.